Dear colleagues, welcome to EndoSwiss 2021. We are very grateful that our meeting has been so much appreciated by the endoscopic community all over the world. As you can see here at this slide, we have more than 1,000 registrations from 87 countries in the world. And now we would like to start with our first session on improvement of adenoma detection rate, current technology, perspective and relevance. And in this session, we would like to demonstrate you the new AI systems for the colon. But I think before, we have to think about what our expectations as gastroenterologists on the novel technology. And there is no better else than Michal Kaminski from Warsaw, who published landmark papers on quality on endoscopy and colonoscopy, who will tell us what our expectations on the new systems. Please, Michal.
Yeah, thank you so much, Stefan. So I feel really privileged to be here and to be starting this session. And my task for today is to explain why improvement of ADR is important for us as gastroenterologists and our patients, and what should we expect or demand from novel technology. So I will start with the first task. And despite the fact that we know that ADR is important, that we are monitoring quality, there is still wide variation among endoscopists in adenoma detection rates. So this slide shows us the results from the Nordic trial. So we strictly monitored quality of our endoscopists, but each of these dots represent a different endoscopist. And when you look on the mean ADR in the study, it reached nearly 30%. So it was meeting the standards, which is right now set at 25%. But despite the fact that we are monitoring really closely, there is still some endoscopists who are below the red line, which means that they are not meeting the standard yet, despite strict quality control. And it is really important to have adequate ADR because there is strict association between adenoma detection rate and the risk of interval colorectal cancer. So this slide shows how adenoma detection rate associates with interval cancer. The yellow line shows the risk of interval cancer among those participants who were scoped by endoscopists with adenoma detection rates above 20%. And it was really, really low risk of interval cancer, whereas the risk was 10 times higher for those participants who were screened by poorer performing endoscopies. So this was the first proof that ADR is really important. And then the next came, Doug Corley, a couple of years later, confirmed that there is association between ADR and risk of colorectal cancer and extended it to show that there is association between adenoma detection rate and the risk of colorectal cancer death. So what you see on this slide is that with increasing adenoma detection rate of endoscopies, you decrease the risk of death from colorectal cancer. If you compare the fifth quintile, so the highest quintile, when the mean adenoma detection rate was almost 40%, the risk of dying from colorectal cancer was 60% lower as compared to those participants who were scoped by endoscopists in the first quintile of adenoma detection rate. But the final proof was to show that improving ADR associates with reduced risk of interval cancer because it shows the causal relationship between adenoma detection rate and interval colorectal cancer risk. So one of the questions is how high should we aim, whether there is a threshold for adenoma detection rate or not. And I think that you can learn about it more listening to our Young Talent Award candidate, Nastasia Pilonis, and she will be telling us about drawing the finish line for adenoma detection rate. So stay tuned for the later session. So now I move to the second part, and what should we expect from adenoma detection rate? And I'd like to show this video despite the fact that when we look at it, we think, oh gosh, how colonoscopy can be done like that? This is a real video from more than 10 years ago. So the quality of image is not enough. The quality of withdrawal is horrible. And it appears that the motivation of endoscopists to find a lesion in the colon was really low. So it shows us what really drives ADR. So the first thing, we have to expose the lesion on the screen, so the quality of withdrawal has to be good. The second thing is we have to recognize the lesion which is actually on the screen. The third thing is to characterize lesion on the screen and to differentiate something which is regular mucosa, normal mucosa, from the lesion which is of interest for us. And the fourth thing is to motivate ourselves to find the lesion. So it seems that these are the four drivers. So how can novel technology help us to address these four issues? So the first thing, exposure of lesion on the screen. We have to improve our withdrawal technique. We know that there is 4 components of withdrawal technique: withdrawal time, fold examination, bowel distension, and bowel cleansing. So what to expect from novel technology? We can monitor withdrawal speed. We already heard yesterday from Yuichi Mori that it's already available. Then we should demand from our manufacturers to facilitate navigation throughout the colon and to expose mucosa better. We have some add-on devices already available. This is one step that we can use. Then we should think about 3D reconstruction and reporting on the percentage of mucosa visualized to tell us how good we are in assessing the entire mucosal surface, and also to monitor cleansing quality and cleansing efforts during withdrawal. And we've seen already some Chinese data which helps us to monitor the cleansing quality instantly during the colonoscopy. Then we have to recognize the lesion on the screen, so we have to identify better what is on the screen, and we need to think about 3 things: image resolution, image processing, and so-called red flag technique. So first of all, we should demand increasing overall image quality. It happens even if we at certain point think that, oh, it's a maximum, the next additions of endoscopes, they provide better image quality. Then we can highlight also tissue texture changes, which will help us to identify lesions. And finally, we need really red flag techniques like artificial intelligence to identify potential lesion on the screen, which may otherwise not be so easily seen by ourselves. So the third thing is to characterize lesion on the screen, and we have 3 things. We may have a normal mucosa, non-neoplastic lesion, and neoplastic lesion. So the first thing is to facilitate decision to dismiss or not taking a biopsy or not removing the lesion. The second thing is to ensure the diagnosis of non-neoplastic lesion and resect or discard or even leave in situ. And the third thing is to identify neoplastic lesion, to automatically calculate it into adenoma detection rate and guide further therapy. And the final thing is to motivate ourselves to find the lesion, because we have to facilitate ADR calculation and reporting. It's cumbersome to calculate ADR, so it should be really automated ADR calculation, and it should be immediately reported to us by the systems, because we need to know it. So what to demand from the technology? This is the final summary slide. We should be aiming at having this data: 95% mucosa visualized, 97% cleansing quality. It should be given by us by the technology. Then the texture should be highlighted, lesion identified on the screen. We should get the information that this is potentially neoplastic lesion, and it should be calculated into our adenoma detection rate. And then the ADR should be reported immediately on the screen, and your ADR is good enough, so we are doing good job. Thank you so much.
Thank you, Michael. Thank you for helping us to defining our expectations. And I think one very important sentence of your presentation was that we not meet the standards. And now we will see if the new AI systems can help us to improve ourselves